Hello, everyone, and welcome to the Early Childhood Health Consultation December webinar, Shared Decision-Making Panel Discussion. My name's Maria Morgan, and I'm the Program Project Manager. Our team is so excited to have you join the conversation today. The discussion will be facilitated by our very own Program Director, Dr. Dipesh Navsaria. The Early Childhood Health Consultation Program is in partnership with the Wisconsin Department of Children and Families and the University of Wisconsin-Madison School of Human Ecology. Our program is funded by the Preschool Development Grant. Our program is committed to supporting Wisconsin's early childhood education providers and truly addressing health-related questions and concerns, offering guidance on best health and safety practices. We envision a sustainable, statewide program that offers health consultation to really improve the quality of Wisconsin early childhood education programs, health and safety practices, and centrally promote health and well-being for children across Wisconsin. The Early Childhood Health Consultation Program acknowledges the American Indian tribal nations across Wisconsin and commits to partnership to truly understanding the best health and safety practices and supporting each unique tribal community. So at this time, let's dive into today's agenda.
Great. Thank you so much, Maria. Really appreciate it. So we'll go through some introductions today, and then we'll spend some time talking about shared decision-making. If any of you had the opportunity to attend our first webinar last month, we talked about the concept of shared decision-making, and now we want to delve into that a little further with folks who represent each of the key key thinkers about children and their attendance at childcare, especially when looking at issues around their health. We'll spend the majority of our time talking and engaging with our panel, have some time for some Q&A, and then close up from there. So again, basic objectives, we'll talk about shared decision-making as a concept as we think about early childhood health and well-being. Think about the different perspectives of the various people involved, which include healthcare professionals, early childhood educators, and of course their parents, and then of course the role that early childhood health consultation can play in offering a resource for thinking about all of these things. So our amazing panel today, which I'm so psyched to have them all here with us, are Corrine Hendrickson, who is a family child care center owner, Dr. Wendy Molaska, who is the current president of the Wisconsin Medical Society, but is also the owner of her own clinic and practices as a family physician, and Barbara Katz, who is the co-director of Family Voices of Wisconsin. I'm also just proud to say that I've known all these folks for a number of years and consider them friends and colleagues in all this work. So always look forward to an opportunity to spend a little time with them. Okay. So now we'll move on to our panel discussion, and hopefully you should be able to see everyone on your screen really well here. And I will begin with a question that I will pass to each of you in turn. When you're thinking about young children, really the 0 to 5 population that represents early childhood, what is the information that you have or wish you had when you're thinking about making that decision? And I really ask you to offer your perspective from each of these sorts of worlds that you inhabit. So let's start perhaps, often the question of childhood illness begins when a parent looks at their child in the morning and says, uh-oh, I'm not sure, if they're ill or not. I'm not sure what I should do. Should I send them? Should I not send them? So maybe we'll start with a parent perspective. And please, all of you, feel free to also add in anything about your role, your lives, anything that I might have omitted in our introduction in order to get us to the panel discussion. So Barbara, let's start with you.
Great, thanks Dipesh. So pleased to be here with all of you today. I live and breathe the world of children and youth with special healthcare needs, and I'm the parent of 3 adult sons. My middle son, Ben, who I talk about a lot with his permission, has developmental and intellectual disabilities. My sons are grown, but I work with families throughout the state who have children all the way from infants up through their mid-20s. And so when I think about working with other families, and when I reflect back on my experiences with my boys when they were young, I often go back to thinking about the world of children and youth with special health care needs, those with disabilities, and thinking pretty much what works for them will work for kids in general. And so, yeah, I mean, my boys grew up with me very attuned to how their health was. I went through different work circumstances when they were young. I worked in offices, I worked at home, and I spent a little bit of time not working. And during that whole time, they each were in different childcare settings, and thinking about what, when they needed to go to childcare and they happened to be sick, what were my considerations? First and foremost is, how would they be out of the home in a different situation? Did they need to be at home? I would think about the contagious factor. Did they have something that could be contagious to other children? I would think about what I needed to do that day. Was it absolutely essential that I work? Did I have some flexibility? So all of those thoughts went around as I was taking their temperature and thinking sort of ahead of the results of what are my options and what are the implications of them either staying home or going to childcare. With children with disabilities and special health care needs, sometimes you have to look at a lot of nonverbal behaviors as indicators as whether they're coming down with something, whether they're not feeling well, whether they're not on top of their game. What I found to be essential, absolutely essential, was honest and open communication with my kids' childcare providers. Being super honest about what my needs were, what their conditions were, and being really aware of capacity and impact of if my child went to childcare that day, what does that mean to other kids? What does that mean to the providers? So that was sort of my perspective on that.
Great, thank you so much. I will also remind our participants, please feel free to use the Q&A button at the bottom of your screen if you have questions, and I'll be keeping an eye on that. Our panelists don't need to worry about that, especially because sometimes you may end up answering questions in the course of your comments, but then we'll certainly circle back and make sure that they are answered at another point. So people should not feel that they need to wait till the formal Q&A section if something occurs to them. So thank you. So this ill child, or maybe not ill child, is now at their early childhood center, and maybe becomes potentially ill later on, has some symptoms, and now we have their early childhood educator looking at them and saying, what's going on here? So Corrine, from your perspective, what do you look at? What are the things that you'd like to know, things that you don't know, that you wish you knew? How do you think about this?
So what I think about is, first and foremost, is this child able to stay and be here and participate with the rest of the kids? Also, back to contagiousness, is this going to turn into something that more people are then, the other kids are going to get it? Obviously, you have some contagion before the child actually gets sick. So there has been some exposure already. That, kind of comes part and parcel. I always assume that the kids have been exposed to something over the course of the week. But I look at, are they able to participate? If there's anything anything major. So if they have a stomach distress, that, immediately that is something that they do definitely need to go home for. Do they have that elevated temperature that is high enough that according to the contract and according to the state laws, they have to go home at that point? I also think about, because I've had a lot of kids with special needs, is this a typical thing for what they have? So I had a child who would sometimes eat too fast and would choke, and it would cause her to throw up. I didn't call on those situations. I've also had young children teething. I've had 3 now. Right before a tooth comes in, they will actually, it kind of looks like baby spit up, but it's not. They actually do vomit. Again, that I know is not them being ill, that is them getting a tooth. So I know it kind of goes along with knowing the children in my care, in my program as well, but then also looking at, is this typical? I look at their eyes. A lot of times you can tell so much by their eyes and the glossiness, if they're acting fatigued. I'm going back to having that trust in the relationship with the parents, being able to trust that they didn't give their child a medicine before they dropped them off, and then this kid's going to get the 11 o'clock fever. And that is something that, again, that goes back to, you have now impacted the other children and myself in this program. As a family childcare provider, I get sick. I actually was sick Tuesday. I had to close in the morning, but 6 o'clock because I was ill. It then turns into like, it then impacts everybody because I am now sick and everybody is, staying home. Interestingly, none of the children have gotten it yet, so that's good. But it just kind of goes back to that, really looking at what is going on, but then also making sure that I communicate with the parents. This is what's happening. This is what I'm seeing. Was there something last night? Was there something this morning that makes you think that maybe, did they not sleep well because they had nightmares? Is that why they're acting tired? Or, hey, heads up, your kid is getting a little bit of a fever, isn't eating much. I may need you to come and get them. Or, hey, maybe send a note to the doctor because I noticed that your child fell off their chair 4 times today, has a 99.4 fever, and has a temperature. Sorry, it's not a fever, Dipesh. A temperature. It's a little elevated, but it's not a fever. So something is going on, and they're at the end of a cold. Maybe they have an ear infection. Can you get a hold of your doctor to see if they want to see them or can get you a prescription over the phone? So that's kind of the steps that I go through, and making sure that I communicate via text so that that parent, or even send pictures, because now with telehealth, parents can send those pictures and send those texts right to that doctor so that they can get that information. And then it also comes down to the doctor trusting what I have to say too. In the past 1 year, I had 19 cases of strep throat go through. I had multiple children, multiple parents get it multiple times. And finally, I knew there was one kid here. I'm like, I think he's the carrier. I think he's the carrier, but that parent could not get that doctor's office to get that child a strep test. Finally, after I kept checking his temperature, he got a 99.5. They accepted him, took him in, did the throat swab. He had strep. He got treated. I didn't have it again in my program. So it kind of goes back to also those doctors being able to trust that what we're saying, we're not trying to get rid of these kids. We're not trying to have them not in our program for that day. It's because there is something going on and it's causing other issues with their health and the rest of our program's health.
Yeah, 19 cases is certainly statistically improbable. So there's certainly something going on there. So yeah, thank you. So now the child appears to have some illness, right? And the parents concerned, the center's concerned, whatever led them to come now, they are now showing up in Dr. Molaska's waiting room and being seen. So what do you look for? What are the things that you think about, and what are the things that you wish you knew, right, that would also be helpful in terms of evaluating this child and dealing with that ever-present question, when can my child go back, or what do I need to think about in terms of their returning or not?
Yeah, thank you so much for having me. I'm really happy to be here. Family medicine physician for the last 20 plus years, and a lot of that has been spent doing pediatric care, especially in rural areas. The interesting thing for me listening to everybody is that I feel like my perspectives have changed a lot after I had my own kids. So obviously, sending your own kids off to daycare and having busy schedules and thinking about everything like Barbara was saying too, like, oh my God, they can't have a fever today. I have too many patients on my schedule. I can't take the day off, etc. So I have a 6-year-old and an 8-year-old currently. So currently now both in elementary school, but they were in daycare as well. Many different things go through my mind when I'm seeing patients in the clinic. For me, I feel like sometimes I have a benefit because I sometimes have the whole family as my patients. And so I can know a little bit more of their background. But what's important for me is knowing some of that background. This is a single mom or a single dad. This is, grandma's raising the kid. This family has a lot of support in the area because all of the grandparents and aunts and uncles are around. This family doesn't have any support. So then what that looks like for them in terms of sending their kids to daycare. And like Corrine and Barbara have brought up, never want to send in a kid that has potential to be contagious because that's going to affect all the other kids in the class, but also trying to get then parents to understand when they don't have a lot of other options for themselves that, this, as much as it's going to disrupt you and your family, this is the right thing to do so it doesn't disrupt so many other people as well. And then the other things to take into consideration are exactly like what Corrine is saying, is to really trust that parents know their kids. They're the ones that spend the most time with them. So if the parents coming in stating concerns to me, I really need to listen to that. The daycare providers spend a ton of time with the kids, so they know the kids as well. So if they're bringing up concerns, you really should listen to them as well. Because it's all this information that will help, first of all, get you to the correct diagnosis and then be able to, provide some of that guidance in terms of keeping kids out of daycare, being able to send them back, and other types of those things. The other thing that came to mind was just things like, my career path has been kind of different because I've worked in big academic centers and employed practices, and now I have my own direct primary care clinic. And I feel like there's some differences there too, where when I was in a clinic where I had, 25, 30 patients on my schedule for the day, and it was a kid that needed a note for daycare, there are sometimes when in the back of your head, you're going, oh, but the kid's fine. Why do I need to see this kid if they just need a note? But a lot of this stuff becomes, really important because yes, the daycare needs the note to say that, yes, the kid does not have COVID, flu, hand, foot, and mouth, et cetera, et cetera. And that can only be evaluated by, me in clinic. And so now that I have a different type of practice, it feels a little bit different to be able to do that. And so yesterday was like a prime example. Mom with a 2-year-old and 2 4-year-olds brings all 3 of them in because one of them has diarrhea, one of them's vomiting, and one of them has a fever, but no other symptoms. And so it's like, trying to figure out what's going on with each one of them, and who gets to go back to daycare, who doesn't, and when that's going to happen. And being able to see all of them at the same time, also knowing mom and the family was really helpful. But being able to then provide that guidance that, somebody's got to stay home with these kids today because none of them are going back in, today after just being seen yesterday with all of these symptoms. So.
Thank you so much. Yeah, I think the pandemic, certainly the early stages of the pandemic, highlighted so clearly like this challenge, that the quandary that parents are put in. Many parents had the ability or were actually made to stay home during the pandemic, but a lot of folks who were considered essential workers, and you start discovering that how many people actually are essential workers, suddenly were faced with the prospect of having nowhere for their children to be during the day, and no one else to be able to take care of them. And that was I don't mean a secondary crisis in the sense that it was not a crisis, but that it was kind of the knock-on effect that happened from the primary thing that everyone was fixated on. And someone said, hey, wait a minute, what happened to you? What about the kids? What are we supposed to do with them? And so on. So yeah, that creates many issues. So in all of your comments, one thing that you all touched on was the communication, and also like you talked about the ideals of communication, which we all know are ideals. If we could take a moment perhaps and just lay out, like, in what would your ideal communication be from, either the healthcare office, from parents, from the early childhood center, that would help all of us make better decisions and more informed decisions when we're wrestling with this question of how's this child doing, when can they go back, recognizing that everyone's busy, there's never enough time, everything seems to take 8 times longer than it should. But let's set aside the time thing for a second and say, okay, what would our ideals be about trying to figure out how to communicate best with each other in terms of what types of information, and also what routes of communication may be most feasible. Barb, could we start with you again?
Yeah, sure. So when I think about communication, I think about other words that were used by Wendy and Corrine about trust and about relationships. And I think what's really a critical part of trust and relationships and communication, it all sort of comes back to you're really working in this as a partnership. You and all the partners, it's almost three legs of a stool, right? So you have to keep that stool balanced, to keep that child healthy and balanced, and the other children that are involved. And in fact, in keeping this little mini system going of a family whose child goes to a child care center is like a mini system, because there are just so many contributing factors. I think that having that relationship, having that trust, and then thinking about how can I, as your partner, help you with this decision. When we talk about shared decision making, you're really talking about how do we make a decision together that is healthy for the whole, for all three of the partners, for the doctor, for the child care provider, for the child and family. And it might involve then creative thinking. And, you know, is there, if the parent is saying, you know, hey, I have a really critical meeting I can't miss, my child's not contagious, they're a little tired, can they come for an hour and a half? To just be during the quiet time and sit there so I can go to my meeting? And can there be some kind of flexibility built in? If you have some agreement on what the sort of the non-negotiables are, right? You can't go when the kid's throwing up. You can't go when the kid is contagious. You can't go when the kid is just not, is just showing a lot of behaviors because they just don't feel good. But if you have identify sort of those non-negotiables and you're sort of in that gray space, is there some flexibility that you can arrive at together as partners that might come to a common solution? That would be an ideal, right? How often would that happen? Probably not very often. But you said speak in the ideals. As far as communication, I have to tell you, my kids were young prior to rampant cell phone use and prior to texting and prior to emails and all of that. So it was the old-fashioned phone. But for me today, being able to text and work out problems is one of the most immediate ways. I know with HIPAA, that's hard to do with medical professionals, but you know, I think asking the family and the medical professional and the child care provider each, what is your preferred mode of communication? And then sticking with that might be a way to go.
Thank you. I so appreciate how you highlighted the trust and coming back to what does shared decision making really mean, right? Is that it also means sharing in kind of how do we reach a solution, and try to do our best to try to meet everyone's needs. We can't always say yes to everything, but you know, as I said to someone yesterday, hey, by doing this, I was able to say yes to everyone. Isn't that great? Because sometimes I'm having to say no because of conflicts or other things that happen, and all. Yeah, and of course, privacy is important, right? We don't want to be spreading stuff out there, and interestingly, right, we fall under different groups of categories of things that we can or can't say, or how we can say those things or relay those things, which create challenges. But I think we can also think creatively about ways to make sure that these are truly there to protect privacy and not to act as impediments to the best interests of children and so on. Corrine, from your perspective, how would you think about this? What are your dreams?
I go along with what Barbara said. In the ideal world, there's the non-negotiable. So these are in my contract. This is the hard stop. You can't come because, again, this is going to get other children sick. I do definitely look at a lot of situations when all of the children have had this, like all got sick at the same time and they're all kind of recovering together. it's a little bit of a different decision than if I have one that's sick, because what happens is if they're all kind of recovering, then they're all kind of tired together. They're all kind of, eating more of a bland diet together, things like that. So, and I will make some adjustments. Like a lot of times when a child just comes back after having had a stomach problem, I don't give them milk for a little bit because I know that's going to irritate their stomach. Just, little things like that, I'm okay with, like, adapting a little bit. But there are some, if we're outside 4 hours a day and you're asking me to keep your child in except for 20 minutes, well, I can't do that because that's outside of my program's ability. But definitely that honesty. And then looking at it as we're a community, we're a family. It's not just me and it's not just your child. We have a family of other children, and having parents understand that whether it's a group center or family childcare, that child's classroom is that child's other family, and that really thinking about those other parents as extended family members of yours and how your decisions can impact them, I think really changes some of that perspective. And then also looking at it as we're a family and we are part of a community, and we together need to push back on some of these policies that are causing the actual issues in our in our programs or with parents. They don't have paid time leave. Well, I'm sorry, I can't help that. And I understand that you may not be able to now pay your bills, and I feel terrible, but that's really on us as a society, allowing that to be part of our policies and accepting that. And we kind of have to look at it as a group together and try and push back on some of that and really explain. COVID, I think in some ways has helped a little bit because employers do seem to be a little bit more understanding about people needing to be out because they're sick, because people don't want to be getting sick from each other. So feels like it's kind of coming back around, unfortunately, but I do feel like there is some pressure there that we could keep up that momentum, because again, it's just really making sure what's in the best interest of that child. You don't want them to get sicker either and then end up, going backwards and having to go back home again for some more days. But back to that open, honest communication, the texting again is wonderful. In the morning, I appreciate it when parents drop off and tell me, hey, my child was up last night for 3 hours. I have no idea why. They had a nightmare. I couldn't get them to settle back down. They're tired. I do have some flexibility in my program. I allow the children to lay down and have quiet time if they need it, if it's not, nap time necessarily, or I can adjust that lunch so it's a little bit earlier because I'm by myself. So I do have that flexibility. Not all programs do have that flexibility, and also kind of understanding as well. If you're a parent and you really need to have a program that doesn't ever really close because there's no, the teacher is sick or the teacher needs a day off, then you have to look at the type of program that you're enrolling your child in as well, and really get to look over that contract, ask those hard questions, and be honest as the provider too, or the program director, and say, no, these are my hard stops. This is why I do the things that I do. We may not be a good fit.
Yeah, I think I so appreciate you highlighting, right, that not all programs are the same, which we all know. But when you start thinking about what are the implications of that in terms of capacity to handle some of these things, that may lead people in one direction or another in different ways. And I do think that it is helpful, right, to know. I know that one thing that I've had to teach many of our trainees, especially when they're working with children or youth with special healthcare needs, particularly who have communications differences and all, right? You're not supposed to magically know what their ability to communicate is. It's okay to just simply ask and say, I've never met your child before. Do they typically communicate verbally or not? Or are they being quiet right now because they're anxious for being here, right? That helps me determine things, because sometimes parents will tell me, no, they're always this quiet in the doctor's office. Really, it's not that they're that ill. Versus no, they would usually be taking apart your room right now, so this is unusual. That sort of information definitely helps and does make a difference. So. Dr. Molaska, how you and I both live in a world of having to think about HIPAA and privacy regulations and things like that. What would your ideal be about being able to get information? Because I think you and I have both had that experience of asking questions about illness, and they say, well, I don't know, I just picked them up and I don't have that information. And you're like, okay, well, what would your ideal be?
Yeah, so I think using all the technology that we have available to us today is definitely one of those aspects, using text, email, telehealth. If we were to do an ideal, I would have the parent and the child in my office so I can examine the child, mom or dad or grandma or grandpa has given me permission to contact the child care provider, and then the child care provider is perhaps on telehealth. So they can give me their perspective of what was happening at the center. You also then lose some of that game of telephone type thing. Well, they said the temperature was 103. Well, it was actually 100.3, not 103. But, so losing out on some of that game of telephone where you misinterpret some of the communication. Because then at the end, if that child care provider is there as well, then I could also talk back to them in terms of, hey, this is what I'm telling the parents about this kid. This is what I think is appropriate for returning or not returning to daycare. So everybody's on the exact same page. But that requires, the kind of buy-in from both the child care provider, who doesn't have the time to necessarily jump on a visit, and then parents being okay in terms of, HIPAA and so forth, being able to have this other provider in the room. But yeah, I really liked what Corrine was saying too, in terms of trying to get parents to understand that the other children, and by extension, their family members, are also part of this, family at the daycare center, whether that's, an individual childcare center or a bigger group where they have classrooms and stuff. I think that's amazing. The other things that I was thinking of, and another reason to pull the daycare provider in is, what is going around at the daycare? Are they seeing cases of hand, foot, and mouth? Are they seeing cases of strep? There are some childcare providers, especially when I was in a rural area, where there was one childcare provider in particular who she used to be a nurse. And so when she would tell you needed to see a kid, you needed to see the kid. There was something for sure going on. And so again, having that trust, having that expertise, and getting to know your childcare providers, which is much easier in a rural area than in a bigger urban area, is sometimes really helpful as well, because they can provide a lot of information on those kids.
Thank you. One of the things that I personally have found helpful, so I think as was referenced earlier, the cell phones and smartphones and all have certainly brought their challenges, including sometimes over communication or over checking in. But one thing I often find really helpful is when a parent says to me in the clinic, let me show you what that rash looked like 4 hours ago, and holds it out, or a video of here's what my child was doing that they're of course not doing now. I have a standard joke about the healing rays in the clinic lights, because once you show up, your kid looks fine. And I think that would be something that if a early childhood provider is seeing something or sees a rash or a mark or something, right, that they say, that being able to, provide that to the family, right, and then let the family make the decision to share it with healthcare, can often be really helpful, because descriptions only go so far, sometimes, and whether we're doing it across, a patient portal like or telehealth or something like that, or in other ways, then it brings all sorts of we can decide how that is, or if they're simply holding up the phone. I know I saw a rash on a much older child, an adolescent, just a few days ago, that it was really handy for me to look at, and it actually changed the diagnosis fairly significantly from what they had been told before, once I was able to see that. So there is that advantage. We all carry now cameras without really thinking about it, and it does make a lot of help a lot of things. I do see a spirited.
We just saw in the clinic as well, a kid had fallen at daycare, got a cut. It wasn't bleeding significantly, but the childcare provider was like, gosh, this is really kind of big. It's not bleeding, but maybe this needs stitches. So sent it to the parent. The parent sent it to me. I was like, yep, that needs stitches. So then they're able to, facilitate that visit, and all because of, those cameras and so forth. So.
Yeah, there's a limit to what we can tell over a flat screen, but there's actually an awful lot that we can do, which is really wonderful. So, yeah. I do see a spirited discussion in the chat about milk as well as mildly ill care. I will just comment briefly on the mildly ill care. We actually had a meeting very recently with our colleagues at DCF about the current rules on that, and had a good conversation about that, and recognizing that, this is hard, and even the definition of mildly ill is something that we had a good conversation on. we have nothing definitive yet, but it is a conversation that has happened or is happening, and I hope we'll be able to offer some guidance and framing on that in the coming months, because that's definitely something that is an issue. So please know, I will just simply say we're seeing all of that, and we're hearing that, and we are having conversations on how to at least think about how to frame that better, because it is a challenge, and even the phrase mildly ill doesn't have any sort of legal definition, so to speak. So we need to start with things like that. So.
You know,
Wonderful.
I just want to interject real quick as you're having that discussion, and not to go down a rabbit hole, but it'll be really interesting if you added in that component of children and youth with special health care needs, perhaps kids who have excessive drooling or kids who have excessively runny noses as just part of their condition and doesn't indicate that they're sick or contagious. And how might that fit into that definition of mildly ill? So just want to offer that as food for thought.
You know, I had a conversation once a few years ago with a respite center, and was actually somewhat surprised to learn how little medical backup they had, relatively speaking, for folks that were often caring for children with very significant needs, you know, and so on. So I think there's a lot that can be looked at in that area for everyone. The general centers that are, you know, largely represented on our participants on this call, but as well as those that may be doing some more specialized care in different ways. Please know that we're certainly noting down these things that are in the chat, because I think it gives us a lot of things that we'll probably spend the next 30 years solving. So just to set expectations. So thank you. This is really wonderful. I do want to invite folks to please, in the Q&A, if there's questions that they have, to please enter those. I do see one question from someone who is asking about COVID exposure guidelines and younger children and quarantine, and asks, they would love to hear what other centers are doing for those kids under 2 around that. I would invite people to perhaps share that in the chat if there's something that they do have there. I will say COVID has been a tough one. And sometimes there's differences between each county in terms of the local health departments, which sadly is, it would be so much better if we had a statewide standard, but for a variety of reasons that there isn't that. And sometimes it's like reading tea leaves to look at one county's standards and then another county's standards and say, well, how are these two different? And, you know, how do we interpret those? And so on. And that's against the backdrop of COVID itself shifting up and down. You know, the landscape we're looking at now, the COVID pandemic we're dealing with right now, is different from even the COVID pandemic of a year ago or even a few months ago. In terms of the things that we have in our arsenal, the implications of what catching COVID means, right? We all remember how significant it was at the outset, and then now with antivirals, vaccination, and other things, risk has dropped, not to zero, but it's dropped significantly. And that's led to a lot of adjustments and so on. So I don't have a straight answer to that question, but if other folks have thoughts about how they're addressing that, please do feel free to share that in the chat. But please, if there's more questions about how one approaches decision-making around health issues and communication, please do so. I see another question that has come in. The temperature cutoff for being excused from care. This center, prior to COVID, it was 101 degrees and then was adapted to 100.4 following COVID protocol. However, DHS says 101 regarding RSV. Fever. We will probably be having a webinar on fever because it goes all over the place. So medically speaking, I will tell you, fever is the line is 100.3, 100.4. And now, if a child comes in and they're at 100.1 or 100.2, I'm not going to blow that off and say, no, that's not a fever. I'm going to say, yeah, it's close enough. It's probably the the thermometer, there's errors in measurement, right, of the ability of the thermometer to pick up, detect a temperature that's within the range of what I would say is, yeah, fine, we're there. 99.2 is not a fever. It is not even a low-grade fever. Corrine, thank you for correcting yourself earlier, because you and I have had this conversation. So I feel heard. Thank you. And I think that it allows us to, from a medical perspective, right, whether a child's at 100.4 or whether they're at 100, 101 or 102 is actually not a dramatic, doesn't change how we think a whole lot. I wish the number told us something useful. It would make our jobs a lot easier. But I think the question should be, what else is going on? What does this child look like? Thank you for the comment in the chat. Never, ever add anything. Do not subtract anything. What the number says is what the number says, whether you take it orally, rectally, armpit, et cetera, et cetera. Do not add degrees. I actually had a child that got hauled in one day to be seen. Their only symptom was a fever. And it turned out that they had a 99.3 that someone added a degree on and said, your child has a fever, go home. They had 0 other symptoms and were excluded simply for that issue. So please don't do that. So at the same time, we also understand that materials like DHS sometimes say things like 101 and so on. We also have some conversations upcoming with DHS about things like the communicable disease chart and all, to try to bring some consistency to this, because it is totally not fair to any of you when you say, is it 100.4? Is it 101? I'm looking at 2 different documents and they say 2 different things. Yeah, not your job to figure out what a fever is. You just want the darn number. So we can we will try to have that conversation as well. So to our panelists, while we're waiting for any further comments or questions to come in, is there anything that we haven't touched on that you think is important about how we think about, evaluating ill children, about exclusion, about communication? What else comes to mind that you think would make that would make all this better?
I think one of the tough things is when a child is just starting childcare, whether they are typically developing or whether they have a health condition or a disability, is for the family, and I hate to put the onus on the family, but I think in this case it is, to really effectively communicate what is typical for that child and what is atypical for that child. I found myself doing that with Ben's brothers, who are typically developing, to say, because each kid is totally unique, and each kid has their own quirks and styles, right? And particularly when they're young and developing and figuring themselves out. And so I think for the family, as much as possible, right up front, to share what is quote unquote normal for that child, what is typical behavior for that child, so that child, my older son is so different than my youngest son, and to communicate that, and I mean, I can't tell you. And then also it was really important for me to communicate what was typical for Ben. I remember getting so many calls as people were starting to get to know Ben in different environments, about he's, being super quiet, or he's, falling asleep, and why is he lethargic, and why is he not responsive? And we think he's getting sick, and it's like, no, he has a neurological impairment, and this is sometimes how it presents itself. And, talking those differences through, again, for kids who are both typically developing and those who have medical or developmental concerns.
Thank you so much. And I think, a parent like yourself who's had these experiences, you would come in knowing to share these sorts of things and offer these sorts of things proactively. But for a lot of families, especially if they're dealing with a new diagnosis, it's not necessarily clear to them. They're not sure what they're supposed to share with people who are used to seeing kids, whether it's healthcare professionals or early childhood educators. So it's on us to think about how do we ask the questions and elicit that as well.
Oh, absolutely. I think, my experience, hindsight is great, right? I did not always do this when I probably should have. So, yeah.
Sure. Corrine, Wendy, other thoughts that you would like to share?
So from my perspective, I think, everything that's been said here is hugely important. And for myself, I think the big things that always go through my mind, and these have been highlighted again by going through COVID and having kids of my own, is how are families being affected by this? How's the daycare center being affected by this? Because both of these things really play a huge part in, this kid, whether they're healthy or sick, or, the parents and whether they're able to go to work or not, and the other kids, providers at the child care center. And so a lot more of this, I think, has come out in terms of how I think about this as I'm seeing kids and evaluating them in terms of, I'll actually ask parents, kid's going to have to stay home. What are your plans for that? How are you going to make that work? Because so many of these things I don't think were ever even asked before. And now it's become, almost, common ground for me to say, how's that going to work? And then just having that open communication, I think, with the daycares as well, in terms of now with every technology that we have available, texting and emailing and, forwarding pictures or whatever, all of those things can be super helpful to helping out the kiddo and providing that guidance going forward.
So if any of you happen to have children that Dr. Molaska might see, you could send her 3 hours of cell phone video for her to review. No, I'm kidding.
My patients seem to understand that I'm a wife and a mom too. So yeah, it's the appropriate stuff that I'm getting. Every once in a while I get something of, the birthday party for whoever, but those are fun things too.
Sure.
I would just kind of like to echo what both of them had said, but then also really I want to emphasize to the doctors that may be listening that we are professionals and that we do understand and kind of know what's going on, because I've had children with special needs. I've had children who, like my own son, for example, he had a horrible cough for years every time he got a cold. And I kept wondering, is this asthma? Is this, viral induced asthma? And I would say something to the doctor, and the doctor was like, nope, nothing. Finally my husband took him when he was 4. He had a tomato eczema reaction thing going on since he was an infant, and Kate went to that appointment, came back with all clear on the eczema piece, but came home with an inhaler. My husband was very upset with me that my son, I had never said anything to the doctor in the past about this. And yes, I had multiple times. And so it was kind of one of those, like, now, this was 13 years ago, I probably would have recorded the cough to, show, have that doctor really listen to it. And I have another child here that, a few times at the end of his cold, he sounds exactly the same as my son and other children I've had that with that viral induced asthma. And I keep pushing it back, like, let the doctor know, please let the doctor know. But now, Wendy, I'm understanding that, if they gave permission for that doctor to talk to me, I would be more than happy to join in on that conversation and explain what it is that I'm hearing and why I'm concerned about it. And, things like that. So I feel like that's something that I thank you for letting me know that is something that, as long as the parents give permission and I give permission, that is something that we can do. Because again, I might be seeing something a little bit different, like the child's here in the morning. That's when the cough was worse. Went to the doctor at 1 o'clock, kid's running around because he's, everything's cleared up. And then that night had the same problems again. And so it kind of just goes back to that respecting each other, trusting each other, having those relationships, and not thinking that, we just need a note to get because we don't want the kid there, or we need the note because, X, Y, or Z. And sometimes even parents are needing the note from their employer saying that their child is sick. It's not even us asking for it. It's their employer that's asking for it. And, some places are very different about what they require for notes and what they don't. But it comes back to that trust and relationships. And we all have to remember that at the end of the day, we're really working on behalf of, wanting to make sure these kids are healthy and thriving, and, keeping everybody else healthy and thriving.
Thank you so much. Maria kindly just informed me in our host and panelist chat that some of my responses to everyone that I thought were going to everyone were not. So I apologize if I was not responding appropriately about the fever question. I will repost what I was saying. Great. I do want to highlight someone else asked about Liz Quinn's question, who she was asking for what other centers are doing. And Liz, we can reach out to you also for maybe some details about your specific situation, because again, like I said, COVID has been a tough one. I even here in the School of Human Ecology, where we have our University of Wisconsin Child Development Lab, our director has knocked on my door. Her office is down the hall with a sheaf of papers from public health and said, "Help! What do I do with these?" and so forth. So it's not an easy answer. So if I had a blanket answer, I would certainly provide that. So Wendy, go ahead.
I just had one other comment, and I think Corrine just brought this up, is that the one thing, especially as we look at society right now and everybody talks about, how bipartisan everything is, how divided everything is, I think the one thing that we always have to look at is what is the common ground? And this is in no matter what space that we're in. And so as the parent, you want your kid to be healthy and engaged. As the childcare provider, you want the kids to be healthy and engaged. As the medical provider, you want the kids to be healthy and engaged. So we all want the kids to be healthy and engaged. And so sometimes we just have to, step back from, the little silo that we're in as parent or medical provider or daycare provider, and realize that we all want the same thing. And so how are we going to get there, and how are we going to make sure that happens, so that, we're not, pulling each other down, trying to get to the same outcome.
Definitely agree. And I think sometimes, I also speaking as a healthcare practitioner, it helps for me when there's a clear question that is being asked. Sometimes I'll ask a family, I'll say, okay, do you know what it is that the teacher is concerned about, or what they're asking, or whatever? And then sometimes they look at me and say, I'm not sure. And I'm like, okay, well, I'm not sure either. We're both sitting here. And of course it's 7 p.m. at night, right? So I can't get a hold of anyone, and time and all that stuff. So even a short note, or, or something of that nature that the parent can even hand to me, is useful. When I did primary care, I actually, that was helpful around behavior. Sometimes I get a short letter from the parents, from the teachers saying, this is what I'm seeing in the classroom. It's like, great. Okay, thank you. That's really helpful in terms of having that sort of feedback. I would not expect an essay on every single child by any means, but sometimes knowing what the question is, because sometimes I'm just thinking, gosh, I'm not seeing this here. And then, then somebody actually asks me the question. It's like, oh, okay, now I see. And now I can actually try to answer that. Well, wonderful. We're coming up on the top of the hour, and there's been so much here, and including all sorts of questions in the chat, and all clearly shows how much I think there's so much value in being able to have these conversations and these discussions. I want to thank all three of you for your insight, your thoughts, and your time, and sharing of your various expertise and experiences over time. It's really something that we're quite grateful for. So thank you so much for everything.
So as we wrap up the conversation today, we would like to take a moment and recap a couple key features of our program, Early Childhood Health Consultation. We're here to really help guide your questions on health and safety for your early childhood care and education programs. And we can do through health consultation, resource library, which is available on demand on our website, as well as webinar trainings such as this, both live and recorded. There's various ways to contact us. You can reach us phone call or text, email, website through our contact form. And also we invite you to follow us on social media. In a moment, we'll be dropping this information also into the chat for your later reference. We'd like to take a moment to also offer a special thanks to the early childhood care and education providers who offer us guidance on best meeting the needs of the programs and the children they serve, including our very own advisory board of early childhood providers. We'd also like to thank our colleagues of fellow childcare health consultation programs across the United States, our current project partners, as well as our past project team members. So as we reach the end of today's webinar, we'd like to talk through a couple quick reminders. The first is in a moment, you can reference a post-webinar survey link in the chat. We invite you to not only offer us feedback and how we can improve future webinars, but also this is an opportunity for you to enter information if you're interested in continuing education credit with the Wisconsin Registry. Also, following the event about a week from now, you can expect a follow-up email with a link to the webinar recording, as well as a link to the post-webinar survey. And then in a couple weeks, expect that any attendance entered through the survey will be entered directly with the Wisconsin Registry, and you can check out this webinar recording directly on our website. We invite you to join us next month in January as we explore the topic of caring for our children. How can early childhood educators use this tool to promote health and safety within their programs? We invite you to go to our website to find out more on this upcoming January webinar. Okay, at this time, we invite you, you can reference the survey link directly on the screen, but it'll also be in the chat in a moment, to directly go ahead and explore the survey. And I will turn it over to Dr. Navsaria for closing remarks.
Thank you so much, Maria. Thank you again to our panelists, and thank you to all of you for coming to our webinar, to all of you who may be viewing this on a recording later on, and thank you for all the great work you do for children and families throughout the state. It really is appreciated, and we're so proud and happy to be able to support you. Thanks. See you next month.